Hello and welcome to LOCUS Radar Reliability Training. Well, that's a good place to start. Couple of things up front. This is not the ideal way to receive training in LOCUS. In fact, the typical training for LOCUS, for radar reliability, occurs over 2 days, is face-to-face, and involves many practice opportunities in which to use the tool and to get good at the way that it works. Obviously, that is not what we're doing right now. So I'm doing this video platform for a few reasons. One is at the time of this recording, we are in the middle of a pandemic and everybody is scattered to the winds and we can't get together and do a 2-day training. Even if this was not the case, 2-day training is not something that most people have the time for. So looking at an abbreviated option anyway. What I've tried to do is distill down for you the basics. Now I should state right out of the gate that none of this material is mine. It's by other people who know way more about LOCUS than I do. And so the bulk of the slide, and you'll see that there's a little caption at the bottom about any reproduction, blah, 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 copyright stuff, was provided by the trainer that provided training for me in training LOCUS. And his name escapes me at the moment, and it's not on the slides, but he did give permission to use the slides for training. So we are completely above board on that. Also, I want to mention that, I'm looking here, that some of the information that I also have built into these slides comes from Jasmine White and Jean Fentner, I don't know, who work for MyFast. And they provide LOCUS training and they do MyFast reviews for LOCUS as well. And so some of their information that given in other trainings, I have incorporated into here. And in fact, we'll be using later in this training a couple of slides of theirs for some examples. So all credit where credit is due. This. Everybody who needs to use LOCUS will have to pass radar reliability. And few things that I encourage around that. There are attachments that go along with this. I encourage you to download those so you have them. The radar reliability is open book. You can use any materials that you have in order to do it correctly. The reason for radar reliability is to make sure that you are using the tool correctly and that you would use the tool correctly in the real world. And in the real world, you can use whatever resources you need to do so. If you do not have a LOCUS manual, reach out to your supervisor so we can get you one. The LOCUS manual, through it carefully, it gets you pretty close to where you need to be able to rate correctly. There are a few nuances that are in the manual that I'm going to point out during this training to try to zero in on where people make errors the most frequently, but it is in the manual. So if you really read the manual well, that is a great resource and can help you to score correctly. Why are we doing this? Well, the reason that we're doing this is that the department says so. So the Michigan Department of Health and Human Services, who's really kind of our ultimate boss and makes most of the rules for us, they determined several years ago that LOCUS was going to be used statewide as the to help us determine level of need. One of the things that they started to discuss in the last year is that they want to use the LOCUS data specifically for decisions, and starting fiscal year 2021, which begins in October of 2020, they will be looking at the LOCUS data specifically to make decisions about funding and other things. So it's really important that our data is right, or as close to it as it can be. The other thing is they are requiring radar reliability. They're requiring that every agency take responsibility for doing training to create it. And so here we are. So most of you at the time of this have some familiarity with LOCUS and may have used LOCUS. I also see this particular training video being used for new staff coming in for orientation. So for anybody who has not used LOCUS, it is a standardized tool, and it stands for Level of Care Utilization System. And it was developed by, oh, you know what? Hold on a minute. I'm going to switch over to my slides. Sorry about that. So I'm going to share my screen and switch it over to that so you can see the slides with me. So hopefully this is working correctly. This is the first time I've done this, so not the best way to launch into LOCUS training, but here we go. I hope you will be patient with me. Oh, and before we dig in a little bit further, at times along the way, this is going to be a while. I don't actually know how long this is going to take, probably a good couple hours at least. If you need to pause the video, get up and stretch, whatever, please do so. I do encourage you to actually pay attention to it. At least download the materials, because like I said, there will be a reliability test, so it's important. And one of the things that I know from our scoring already, we have a high error rate. So if you've used the LOCUS a long time, I'm assuming you've been doing it right. Maybe you have been, but a lot of people have not been making the common errors that cause the scores to be incorrect. So be warned. So the LOCUS is developed by the American Association of Community Psychiatrists. And it's a system for evaluating the current status of clients and their needs based on 6 evaluation dimensions. It looks at information you gather during assessment and translates that into recommendations for placement level. It's a decision support tool. Help to make and document clinical necessity for client placement. I'm looking to the side, you'll see, because I'm on a different screen is where my pop-up is. So that's why I'm doing the way that I'm doing. So we are required to do the LOCUS for adults who criteria for serious mental illness. And we're required to do them at intake, annually as part of their annual assessment. Annual assessment is a contract requirement from the Michigan Department of Health and Human Services. At least every 364 days, we are to assess we are working with, their needs, and how to address them. So this is part of that. And it is also required for planned discharges. So we do not have to do a LOCUS if somebody disappears and we end up closing the case because they just dropped out. But if we have a planned discharge, we have to do a LOCUS for that. It's also recommended but not required to do at times of transition planning. And so that specifically would be if they were being transitioned to some level of care. So like from a group home to a lower level of care, or from independent living to a group home, that sort of thing. And generally, it's a good idea for identifying the appropriate level of care for them. It doesn't diagnose, and it recognizes that needs can change, and sometimes quickly. So there are specific dimensions within the LOCUS. Those are listed here. And we score within each of the dimensions. So risk of harm, functional status, medical, addictive, and psychiatric comorbidity, recovery environment, treatment and recovery history, engagement, and recovery status. And dimensions then link to levels of care. So the outcome of the scoring of the dimensions determine the level of care that a person would be recommended for based on the LOCUS. So recovery, maintenance, and health management, low intensity community-based, high intensity community-based, medically monitored non-residential, medically monitored residential, and medically monitored managed residential, excuse me. Now, a couple of things to know for us, for the including the mild to moderate dual eligibles, who we don't do the LOCUS for. but the rest of the adults that we work with who would qualify for our services, they should be scoring in a level 3 or above. So high intensity community based going into service, lowest that we would typically go for approving somebody. So that's where the locus helps, does not determine, but helps us figure out if somebody might be eligible at time of intake. A person could, on the way of transitioning out of pathways, score within low intensity community based or recovery maintenance. Should not typically score within level 1 or level 2 if they meet criteria for our services. They should be 3 or higher. I think I mentioned that again later, but so foundational principles. So it's interactive, it's simple, yet specific, quantifiable. It provides a spectrum. Part actually that gets a little confusing for people. So the locus is used both for behavioral health, level of care determination, and substance use determination. And so it's got an integration of both. So I'm going to say this a few times throughout the training because it is the most common error. Well, maybe it's probably second most common error. You don't score both. So all of these domains that we go through, questions related to associated risk. There are questions related to behavioral health concerns, and there are questions related to substance abuse concerns. And based on the presenting problem, why someone's coming to pathways. And because we're mental health, people are coming to pathways, behavioral health concern. That's what we're scoring against. I know what you're thinking. Well, sometimes it's not a behavioral health concern. Sometimes they come here, but it's really a substance abuse concern. In that case, they shouldn't score very high on the behavioral health part. And we don't score the substance abuse in any field except for comorbidity. So it's confusing because they're both listed as options when you're scoring. But for us in behavioral health, as part of community mental health, answering the behavioral health questions. There are a couple exceptions to that, which I will touch on later, but that general rule holds very true through almost all the fields. Simplicity, it is easy to use and it doesn't take very long. You can, once you're familiar with it, you can rock through it pretty fast. And it is adaptable to a variety of settings. Not that we care because we're one setting. And then there is reliability and accuracy. When people are appropriately trained in past reliability training, answer the locus pretty similarly, and scores end up being close. So the locus does not prescribe program design or anything for that matter. It does not specify treatment interventions, limit creativity, or negate clinical judgment. All of those things are still necessary and required. And when it comes to how we best meet a person's needs for services, all of those things are necessary. And we should always be looking at what their needs are, they require, and what service array will best meet those needs. And that should always be tailored to any individual. The locus does not limit that. So, as I mentioned, for when we're scoring, the presenting problem is always behavioral health concerns. Always. The only time we answer any option that is addresses substance abuse is in the dimension medical, addictive, and psychiatric comorbidity. It shows up there. That's where we will specifically rate it. And so, a lot of the people that we work with, very high percentage, have some type of substance use and or substance use problem, and shows up medical, addictive, and psychiatric comorbidity section. We score it there. A soft exception under risk to harm. You can score the substance use in that as well, only when it creates a direct risk to harm. For instance, if I were the client and you were doing locus on me, and I drink a 6-pack at night not scoring risk of harm because it's not creating risk of harm. If I drink a 6-pack, then I get in a car and I drive recklessly, or I become violent, creates a risk to harm to self and others, and it can be scored. So it's the only exception. It does not get scored in any other domain. We have to think that here's another area where people get things a little messed up, and it is a little tricky. We have to be very mindful of the difference between chronic and acute. So in the way the scoring works in LOCUS, the higher the score, the greater the concern, the limitation or impact. So acute problems score higher than chronic. So an acute problem is going to score 5. Chronic problems will score 2 or a 3, but never above a 3. Chronic never is above a 3. And that's really important because we have people that their level of impairment when compared to general population, but if it is their chronic baseline presentation, it cannot score higher than a 3. 5 specifically is for acute states that are concerning. So stability is there we go. My screen froze. Sorry. That's weird. I'm the only one on here. It doesn't seem like it should be a bandwidth problem, but okay. Baseline stability is still considered stability, regardless of what that baseline looks like. So psychotic all the time, for a long time, that's baseline. Most dimensions are focused on what is happening in the here and now and not interested in history. It says here the exception is risk of harm, treatment, recovery history. Risk of harm because past patterns affect when you're looking at risk, particularly for violence towards self or violence towards others. And treatment and recovery history has history right in the name. So yeah, we're interested in history there. Otherwise, everything else is about now. Now, that does not mean today. It doesn't have to be limited to that. And in fact, the LOCUS doesn't specifically specify timeframes that are considered now, but we're really looking at recent. So anything over a couple of months or so is probably starting to become out of bounds for scoring a LOCUS. It really wants to know what's going on with the person now, what impairment looks like, and what needs are, and what level of service is necessary for today's needs. So scoring tip, the what, not the why. LOCUS is concerned with what is happening, what the person is doing. It's not interested in why. That is easy to fall into when we get curious about why is that we start to score stress across dimensions. And this is probably the highest error for scoring, is that we place stress upon multiple dimensions. And the only place that stress is scored is recovery environment. So like substance use, which is primarily scored in the comorbidity, specifically the recovery environment. Related to that is perceived stress. So if I'm working with somebody and they're currently homeless, I'm worried about that. Influence my scoring. But if it's not actually a stressor for the person, it's not scoreable. So the why and my own perception of it, not looking for why. Those of us who are therapists, we're very interested in why much of the time. Why doesn't matter here. We don't care about why in LOCUS. We want to know what. And focusing on why will lead you astray. So, independent criteria. So one of the things that LOCUS looks at is that there are certain things that identify higher risk than others. So it has within it, independent criteria. I'm looking at my book just so I can keep all my stuff straight. So what independent criteria identifies is that if a person scores a 4 or a 5 in any of the first 3 dimensions, so that is risk of harm, functional status, medical, addictive, or psychiatric comorbidity. If they score a 4 or a 5 in either of those, they will always be recommended of the residential levels of care. Always. Doesn't matter what the rest score. You can score 1s and everything else. If there's a single 4 or a 5 in one of those first 3, it's going to say residential level of care. Now, that does not mean that if a person is not in a residential level of care, you don't score a 4 or a 5 if it is correct to do so in one of those 3. Doesn't mean that at all. In fact, another error is scoring towards the outcome that you want to see the locus at. And we're not supposed to score it that way. We should score it based on the needs. Scoring a 4 or a 5 in the first 3, believe the person needs a residential level of care, may indicate you're overscoring. Just something to pay attention to and be mindful of. But so for us, when we do the locus, it's integrated into Elmer, our electronic medical record. So it's all electronic. We don't add it up or anything. The locus manual actually, if you have that and look at that, it's got how to score it and how to add it up. It does it automatically. So regardless of what the total score will be, if you've got a 4 or a 5 in one of the first 3, it's going to say residential as an outcome. Let's dig into some of the dimensions. So dimension 1 is risk of harm. And it measures 2 different things: the degree of suicidal, homicidal ideation, behavior, and or intentions, and the degree to which the client's perceptions, judgment, or impulse control are creating danger for them or others. So you have to determine, what is the client's current level of distress? What do they look like? This is the part, so what this part of the slide is getting into is, remember, locus is part of an assessment. It's not a standalone thing that you're doing out of nowhere. So at the time of assessment, indicating anything that is identifying distress. And is intoxication a factor? Because that could create transient, right? But again, we're only scoring drug alcohol if it specifically impacts direct risk of harm. And that we don't want to load stress and we don't want to predict. So just because we're concerned that they could get hurt because they're engaged in higher risk behavior, say opioid use, or they're injecting, or that kind of thing. That does not, in and of itself, an immediate risk of harm in what the locus is looking for, compared to when you think about presence of suicidal, homicidal ideation, or impulsive behavior of a degree that places the person or others at risk. So think about how you look for specific risk factors when looking at the locus for risk of harm. Don't fall into the substance use trap. Just because they use does not mean you should be scoring against the use. Only if the use creates a direct risk of harm. Direct, not a possible. Independent criteria, if there's a 4 or a 5. So here's another little caveat. So it's the difference between chronic and acute. So some of the people that we work with, there's somebody that I work with who has a high level of chronic suicidal ideation. They think of suicide. They have most of their life. Their baseline is they have thoughts about suicide. They do not take action, and typically do not have specific plan that they intend to carry out. Chronic baseline is disturbing suicidal ideation. So they would score a 2 or 3. at time of interview, it changed their and that they are considering enacting, it becomes acute, they would score higher. So in things like risk, even things that might be concerning, we need to be mindful of, is it acute or is it chronic? And chronic scores lower than acute. Next dimension. And as mentioned before, this is usually a longer training, so I am moving through these pretty quickly, which is why I really encourage people to lean heavily on the book, to really look through the criteria and the questions that exist in the for you to link to in determining what you would select. So for dimension 2, that's functional status. So it addresses 4 areas: the ability to fulfill obligations such as work, school, or home, the ability to interact with others, family, friends, socially, coworkers, relationships in general, and whether or not they've changed. ADL status, so that's things like eating, sleeping, overall activity, taking care of themselves, things for themselves, cleaning up their place, stuff like that. And then ability to care for themselves. That also overlaps some with ADLs, like appearance and hygiene, but it also then is, decision making and paying bills and things like that to keep the environment going. So this too, always, you want to look at the difference between acute and chronic. One of the things that LOCUS is trying to see is whether or not a level of care may need to be changed for a person because their status has changed. They now have some acute functioning that is different than it was before, and that may mean that they need a higher level of care. They may need more intervention. So folks have, for instance, chronically poor hygiene, do not take care of ADLs, do not pay attention to that, and they would score in the chronic range for that, not acute. If you score them as acute, when it's just part of where they've been for an extended period of time, you will inflate the score. We don't want that. So you want to compare their baseline to their ideal level in the past. So that's when there's an acute change. Too, you want to be looking at when something changed. What does that look like? But even when you're looking at chronic, if they functioned higher at some point, that's good information, and that does influence your scoring. So it may go a little bit higher, but if it's chronic baseline, it's still going to be chronic baseline. It's not going to be higher than a 3. So if they used to function higher in the past, and their new baseline is below that, then that might move them towards the 3 instead of towards a 2. Dimension 2, as mentioned before, is also one of those areas that identifies independent placement criteria. And so that's where the 4 or 5. Dimension 3, medical, addictive, psychiatric comorbidity. So comorbidity is recognized as another condition that is or has the potential to exacerbate the primary or presenting problem. Imply the importance of one over the other. That's a really important detail. So, for instance, somebody who is co-occurring with substance use disorder and with mental health, who has a serious substance use problem, scoring that in the comorbid is not saying that we're identifying the behavioral health as more important than the substance use. In fact, the opposite may be true. Comorbid, because what we're scoring the bulk of the locus on, specifically the behavioral health. It's not about what is a bigger impact, about what the primary presentation is about. And then in this comorbid dimension, we're looking at the other things that impact. So we're looking for the interactions of co-occurring illnesses, and it can be more than one. We can score, so a person could have serious health concerns, substance use, and we look at all of that when we're scoring for comorbid, okay? So if there's multiple, vary. and then you score the secondaries as comorbidities. An important thing, somebody who's using substances that result in withdrawal and create physical risk, for both. That withdrawal is considered a health risk. And so they would be scored on that as well as their use. And so when you're scoring on multiple, you're going to pick in the comorbid options, the one that is the highest. Okay? So you can select more than one thing, but what will score is the highest one when you're different levels. And then this is the last area that if you score a 4 or 5, medically recommended residential as an independent placement criteria. Dimension 4, recovery environment. Or environmental factors that contribute either positively or negatively to the onset or continuation of mental illness or addiction. For us, remember this isn't my slide, I modified some, but I missed that piece. It really is the mental illness. That's what we're looking at. Positive or negative impact on the continuation of the mental illness. If the client is living in a residential setting, and that includes our AFCs, particularly our specialized residentials, because they get a lot of support in that, you want to rate this based on what it would look like if they were not receiving the support in their living environment that they are. For instance, if they're doing well in a specialized residential AFC, a lot of support in there. If they have no family, they have no friends outside of the home who would be part of their life and helping them in a recovery environment. So if they suddenly moved out, they would be completely on their own. Score it in regards to that they do not have social support. Two scores within recovery environment: level of stress, what in the client's life is impeding progress or affecting towards. I wanted to look at a little bit. As we're moving along through this, I realized that hitting a couple of what the 1 through 5s would look like might make some sense. So I apologize that I didn't do that earlier, but we'll circle back around, I'm sure. In a longer 2-day training, there'd be a lot more time spent specifically looking at the criteria that you pick from in order to do the scoring, which of course I'm not doing. So that is the downside of taking this kind of shortcut. So, for example, though, in regards to level of stress. So 2A, so it's when you rate the locus, and like I said, I didn't go through this, there's 5 different levels within each of the dimensions. And within the level, then there is an A through F or A through G or something like that. And those are the different options that you have to select in order to pick what the impairment looks like. And your job is to find the one that most matches. Okay, it may not be a perfect match, but you want to find the one that seems to fit the situation the most. So for instance, under living environment in the level of stress, A is presence of some ongoing or intermittent interpersonal conflict, alienation, or other difficulties. Compared to level 3A is significant discord or difficulties in family or other important relationships or alienation from social interaction. And level 4 is serious disruption, 4A, serious disruption of family or social milieu, which may be due to illness, death, divorce, or separation of parent and child, severe conflict, torment, and or physical or sexual mistreatment. So you see how those kind of ramp up as you go through them. So also as they ramp up, you're looking for danger in the environment. That's going to affect scoring. Performance issues, real or perceived in their life roles. That's their perceived, not our perceived. And disruptions in family relationships, as mentioned before. So when we're rating stress, this is one of those important areas, we're rating their stress, not our stress. Situation sounds really crazy to us, and we would be really stressed in it. But for them, it's just another Tuesday. Doesn't really change anything. It's at least chronic, so it scores lower. It may not be stressful for them at all. We need to pay attention to whether it's stressful for them or not. We can't project what we think would be stressful. The second area is the direct level of support that they have. So what do they got in their life that assists them in supporting treatment or moving towards recovery? Is in their life that helps them maintain mental health in the face of stress. So it's also looking at that. So both of those factors are in there, and they're broken up. So under recovery environment, you've got the first section that has starting with 1, the low stress environment, and goes all the way up to 5 environment. And then you have a B, level of support, and it starts with 1, highly supportive environment, all the way to 5, no support in environment. So that goes back to that, that example of I'm living in a structured setting, a specialized residential, I'm doing really well, but if I moved out, I'd be completely on my own. And what that all looks like, I'm going to score a 4 or a 5, which then would also indicate I'm in the right setting, by the way. I hit on much to this, but you can see the big bolded thing. If the person is in ACT in this dimension, under the support, they're in ACT, they score a 1 if effectively engaged. Now here's the kicker. What is effectively engaged? You don't have to greet you with open arms and go, oh, I am so glad you, my ACT worker, are here to see me today and provide me with medication and support. They don't have to do that. If they're basically doing what they're supposed to, even under duress, like they're following a court order, and they tell you the only reason I'm doing it is because I'm on a court order, they are, per locus, effectively engaged. Remember what, not why. So if they're basically following their treatment plan, they're basically doing what they're supposed to, CT, and they're doing those things, it's a 1. It's the what, not the why. They are doing it. Go into why are they doing it? Are they motivated? Personally for their own growth. Don't care. Are they engaged? Okay, dimension 5, treatment and recovery history. This assumes a client's history with treatment may be give some indication of how they will react in the future. So when we're looking at this, we want to be looking at treatment history that is related to the presenting problem, not unrelated. So if when they were 10, they were in counseling because their parents were going through a divorce. Now they're coming in because they are dealing with depression. Those two things are not likely directly correlating. And they were not, if I was not being treated for depression, not relevant for what's going on for me now. But it's looking for past exposure to treatment and past history of managing recovery once treatment has happened or they're at a basic care level. So it's how they've responded, how well they did, and how was afterwards. So some of how this is supposed to help us in some clinical decisions is if they had difficulty engaging in the past or experiencing success in treatment or effectively entering into recovery around an issue, I want to consider more intensive services. It's actually something I've got on my board. So there's a related thing. It's called treatment inoculation. And this is a research-based concept. And basically what it demonstrates is that when we intervene by treatment that is below meeting the level of need, only does it tend to be inadequate to support recovery, but it inoculates the person against recovery. So if we start too low, oh yeah, this is way off and we need to ramp it up later, have a negative impact on what recovery can look like later. So it's important to do the best we can to match the correct level of intensity of intervention with what a person's needs are. And one of the things that we can use to help us with that is, in the past, and was it successful? And if it was not successful, one of the possible reasons is that it may not have been intense enough. It's not the only reason, but it is one of the possible reasons. So in this sense, so clinical judgment, what types of more intensive services you do not need to repeat past mistakes, use flexibility in LOCUS. I think that's really important for us. And it's particularly important for us in, it's easy to fall into habits about, here's what you get if you're in our program. That's not really how we're supposed to operate. We're supposed to operate based on what are your needs to offer that will meet your needs at the level of your needs. This looks at this and can help with some decision making around that. So if they have a lengthy recovery history, they've been involved in lots of things, more weight should be placed on more recent experiences. So if 10 years ago, I didn't have very good experiences and this would have scored me, poor in which is poor response to treatment. But 5 years ago, I engaged, I was able to effectively utilize services and had a period of recovery afterwards. That's really what you should lean on in the scoring. That more recent gives a better picture of what we might expect and what might work for me. And then if there's no prior treatment, that's a 1A. So what is recovery? It's a period of stability with good control of symptoms. And we have to use our clinical judgment on that. What does that look like for the person? Movement made by them and, sustained in some way. So that it doesn't have to mean like, hey, all my problems were gone and I just am doing great. You really have to look at the broader context and use your judgment on what that might look like. Dimension 6, engagement. So this actually, when scoring this is similar to what I touched on before about when we're scoring somebody who's an ACT and they get a 1 if they're considered engaged. That is very similar in this when looking at scoring engagement, that seeking help, this is why, so they're showing up, following the basics of their plan, score lower if they're not. Even if their insight is limited, following through, they would still end up scoring lower. So they can be complaining, but doing what they need to do. And they're going to score lower than somebody who is not doing what they need to do, does not recognize the need to do what they need to do, and so they're not doing it. So in scoring it, we're looking at their understanding and acceptance of illness and treatment. And again, that even it's getting their foot in the door if they understand that they have to take their medication, even though they don't want to. And so, I mean, that's some insight. So I don't think I need it. I don't really want it, but I'll do it. That is some insight. It's limited, but that's very different than somebody who's flat out refusing from a scoring standpoint. And then they're willing to engage in treatment and recovery. I've covered that already. So consider their desire for change, their ability to trust others, their ability to interact, of help, and their ability to accept responsibility for recovery. Again, looking more at the what than the why. What are their actions telling you? What are they doing? Not just what they're saying, and not whether or not you think they're only doing it because they're on an order, and you think that because they tell you that every time they see you. If they're doing it, they should score lower. So basic insight and help-seeking behavior should lead to lower scores. Beating that horse to death. This includes following through only if being in order. Remember, this is not my slide. So I'm not making this stuff up. So self-referred, seeking behavior. Coming to appointment, that's help-seeking behavior. Takes meds, even though they don't want to, that's help-seeking behavior. And all of those require at least some level of insight in order to do that. Okay. Overrides. So any of you who have used a locus with overrides. So what an override allows you to do is, so when we complete the locus, tallies a score, and based on that score, identifies a level of care and makes the recommendation for level of care. An override is when we are not going to follow that recommendation and we place the individual in a different level of care. So if the locus score comes up with identifying a residential level of care, and we do not place them in a residential level of care, but in a intensive outpatient level of care, we have to use an override to identify why we're doing that. So here's the thing with override. We're going to spend a little bit of time on the overrides as far as like how you would do it, when and stuff. But here's the bottom line. This is one of the things that the department's going to monitor. In fact, NorthCare has already developed a report to track overrides. And there's no magic number, but generally, see 10% or more as a problem. Let that sink in for a minute. If you're already doing the locus, you might have some sense. How often do you select override? Both NorthCare, guided by folks at the state level, particularly through MyFast, have identified that somewhere around 10%, probably the mid area for overrides in a given system. I haven't looked at this data, so I don't know what we run. From the little bit that I have looked at some of the locus stuff in preparation for this, the areas we've already touched on, I think we tend to score a little bit higher than in the locus for people than they really should be scored. Sometimes leads to overrides. So this is something that we have to pay attention to because our scoring affects it. Now, that being said, they have identified, that window of somewhere around 10%. Again, it's not a magic number. Doesn't mean that we're going to get a budget cut if we're at 12 or something like that. In fact, I don't even know what the options are if, say, we're running at 20%, though it will definitely draw attention by at least NorthCare and probably the department, since this is one of those things that they are paying a lot of attention to right now. And do an override when it's appropriate. And there are and clinical rationale that makes it appropriate. Okay, so we're going to delve into that a little bit. Okay, so when to use a rationale, or when to use an override? When there's a clear and compelling rationale to do otherwise, right? So different than what has been recommended. When it's customized according to local needs or cultural issues. I'm not really sure on the cultural issues exactly what that might mean. Though maybe there might be certain living situations or such that would. But an example of this, as far as local needs would go, we don't have ACT in all 4 of our counties. So somebody might seem to most appropriately be at an ACT level of care, say in Luce County, and we don't have ACT, so we're going to be doing something else. And as long as we're meeting their needs, and we can demonstrate that we're meeting their needs, we may also end up in adjusting that to a lower level of care. Okay. So to the next part, we can adapt an array of services and level of intensity or resource intensity. Another example of that might be person scores into, let's see, it would be let's see. Yeah, it's like a level 5. Okay, so level 5 is medically monitored resident. So now this identifies this as often it's a facility, it's like a brick and mortar residential or a nursing home, but our specialized residentials kind of flow into that too. Not really written with those in mind. So those kinds of facilities don't fit the best, but that's where, level 5 is where we're thinking some type of residential. But let's say the person scored there, either because of the independent placement criteria or just total score. Really wants to live independently, has a fair amount of natural supports in their life, and maybe some other resources can come together, enough supports in place where they could still successfully live on their own, at least for a while longer. That would be a good example of an override. The score may come out to say they should be in a level 5, but we might place them in a level 4 instead. Then we would need to explain that. Identifies that an example of the override might be when there's a level of care unavailable. So specifically, so level 6 is medically managed residential services. That is particularly for us psychiatric hospitalization. So any of you who have been doing crisis for a period of time know that sometimes that's not available. So a person could score in that area and there not be a place for them to go for that service. So then we would override, demonstrate how we're meeting their needs safely of that level of care because it's not there. Okay, we do that sometimes with people too that we see as appropriate for. They might score the 6, and we think they're appropriate for the state hospital, but there's a waiting list. They can't just go right there. So we are then providing a lower level of care, perhaps or even a 4, because that level of care isn't ready, and we would hope they would go to it soon, but in the meantime, we still have to meet their needs. So we'll be outside of the level of care recommendation because it's not available. In the example I gave earlier about the person who wants to stay independent, so a person's choice could impact it too. Particularly could impact, say somebody has made progress and they could transition down to a lower level of care, but they really don't want to yet. They really don't want to, and they want to stay at the specific level of care. There is some room for some leeway in that, based on their choice. Necessarily last forever. Example that is given in training is somebody working with ACT, is doing well, LOCUS scores them at a lower level of care, say a level 3, and they really are connected to that support system. They don't want to change it. And maybe they haven't been, at that point of stability for a really long time. Well, you could make an argument that they could continue with ACT for a while longer. Really make sure that they've got their feet under them and that they're continuing in their recovery. So a person's voice does matter in the level of care determination. And then with transportation, it really kind of, again, for us, kind of goes back to some degree with that inpatient hospitalization. Sometimes there's just not a way to get them there either. And so that might be it. There always must be supporting clinical documentation. So it happens in kind of at least 2 ways. One is when you do an override in LOCUS, there's a little narrative box and you're supposed to explain yourself. You don't need to write a book, but your explanation needs to be better than because I said so or something. Needs to be more than a couple of words. It needs to clearly identify why you did what you did. In addition to that, really need to be that really needs to be reflected in other documentation. So since LOCUS most commonly is happening in conjunction, assessment conducted. BPS that you write connected to the assessment you conducted. If you're going to do the override, really should address that in the BPS. It may be addressed in a few different places. Disposition would be an obvious place for that to end up in explaining why. This is really important from different angles. One, it's important for clinical communication. So anybody else who's coming into the case who doesn't know the history and is going to rely on documentation to get caught up, know why the locus scored, say, 24, but the person was placed in a level 4 for the array of services that they got. You know the rationale for that, if they're going to be able to make good clinical decisions moving forward. It comes to, like, why are we doing what we're doing? Okay? And then that's the kind of thing that's, when we're audited, they will look at. They will look at our overrides, and they will look at what clinical documentation exists to provide adequate explanation. Person's in a level 4 versus a level 5. Related to that really has to do with risk. So when we go outside of LOCUS is recommending, demonstrate that it's wise. What we're doing makes sense. If something bad happened, explain why we put somebody in a lower level of care than what they scored in the LOCUS. That creates a liability concern for everybody involved. And hasn't been well documented. Question of whether or not we did the right thing really matters much, because what that in those circumstances, unfortunately, is what's documented, what you may know. And so we can absolutely do totally right by somebody and something bad happened. Chart doesn't demonstrate how we did what was right by them. That can be a problem. And that's one of the things with this tool. So it creates data that makes a recommendation about a certain level of care based on the person's needs. If we go against, which we absolutely can, go against it, it needs to be clear why we went against it. And it needs to demonstrate that their health and safety and recovery are considerations in that decision. So when considering an override, do you have sufficient data? Do you have sufficient information to have scored correctly and to know whether or not appropriate and how things might work? Clinical documentation that supports the criteria. Have to look at individual choice, but we also have to look at medical necessity. And sometimes we can weigh those out, and depending on what the thing is that we're looking at specifically, we can be flexible or not. Particularly medical necessity around things like safety, it's hard to have very much room to budge around that. Okay? We can look at service level availability, though, that being said, I can tell you the department really doesn't care what we have available or what our staffing issues are or things like that. They really care about providing a full array of services and meeting people's needs. So that's in there because I didn't create this slide, but that's kind of a weak one. And again, under audit, yeah, I've never been in a conversation with the department in particular where they cared one bit about practical challenges for us. They just want us to do it. So, and then sustaining level of care versus transitioning. So that, again, I mentioned it before, having a slower transition for somebody, particularly if they have a long history of really chronic problems, and technically the LOCUS says they're ready for a lower level of care, but you're providing them more support at the same level to help aid in that transition and make sure that it's got some ability to last for them. And that's arguable. Absolutely. And then person-centeredness. So that goes back to the individual choice part, what the person wants for their own lives, how we meet them where they are. Those are all relevant. And part of the relevant clinical argument for outside of the level of care that may be recommended by the locus. So I hope in going through that part, I was able to strike a balance between the warning about don't just disregard the level of care that the locus is coming up with. We should not be doing that. And balancing that with, and you do get to use clinical judgment on what we're doing. Both things. And generally, the powers that be have a lot of faith in the locus. You may or may not, but the powers that be do. And so that's where, if we have a high override rate, we'll see that as a problem for us. So we do need to be mindful of that. We need to pay attention to it, and we need to make sure that when we're overriding, there's good reason for it. It's supported and arguable. So some of what I encourage with this as we're trying to get better is, again, going back to what I said earlier, the department's going to be using our locus data for decisions, and they've been talking about even using it to affect our funding. I don't know anything more specific than that, because they haven't gotten more specific as far as anything that I have seen. But that's the part that scares me. I don't know what they want to do with that. So it's important that we are good at this to some degree. So we need to help each other out with it. Okay. So levels of care. So here they are. So as I mentioned before, so basic services and recovery maintenance, those are not generally levels of care that somebody would enter into, even in other settings necessarily. Low intensity community-based services and up tend to be, now, so here's the way that it works from the scoring, right? So I mentioned before, so when you're looking at any of the dimensions, it's going to score 1 through 5. So within, so I'm going to use treatment recovery history just because that's close to where the levels of care are. So treatment recovery history, we've got a score of 1, which is fully responsive to treatment and recovery management. Under that, there are 3 options. And so if one of those fit the situation the best, that's what we would select. 2 is significant response to treatment recovery management. And under that, there are 2 options. And if one of those fit, we would select that. Then there's 3, moderate, or I don't know that one. Response to treatment and recovery management. I'm recording this kind of late in the day too, so you know. So now we're into moderate response, and under that there are 4 options. So whether I see the A, the B, the C, or the D as most appropriate, it's going to score 3. Right? And then under 4 response to treatment and recovery, there's 2 different options, and under 5, there's negligible response to treatment, and there's 2 options. So regardless of which letter I pick, the score will be determined by which number it's under. And so with each dimension, put together, and that gives us a total score, which determines where the recommendation is. Again, keeping in mind in those first 3, a 4 or a 5 automatically overrides the score and places somebody into a residential care level. Okay, so with that in mind, a score that is under 13 is level 1. So this basic services, no, actually basic services is a 0. It's not a service level. Sorry about that. So that's a 0. So recovery and maintenance, that's the level 1. And that's a score below or equal to 13. So 13 and under, do that recovery, maintenance, and health management. We would typically only see that well on their way out the door for us. Okay, and generally the services around that are community services and maybe things like self-help groups and stuff like that. Level 2, low intensity, community-based, that's a 14 to 16, so there's only a 3.3 point range. Again, not a level of care entry point for us. Could be an exit point. They could be there on their way transitioning out. But they could still need psychiatry or some therapy or something like that, but it's going to be a lot less intensive. 3, high intensity based. So that's a 17 to 19, and that's our primary entry point. Okay, so we could say a score of a 17 or higher qualifies somebody for services. It's not that direct a line because we still have to provide our clinical assessment and be looking at that there is a diagnosable behavioral health condition and that there's a substantial limitation associated with that. By LOCUS standards, that's likely to show up then with a score of 17 or higher. For the medically monitored non-residential services, that's where ACT typically would be at that level of care. That's a 20 to 22. And then level 5, medically monitored residential services. So that's residential treatment. It's 23 to 27. And then level 6, medically managed residential is 28 and above. And that's typically a hospital environment. So either acute hospitalization or longer term hospitalization. It can be provided in what they call a freestanding non-hospital. So I think like Pine Rest would fit into that. I think might be the kind of setting that they would be talking about because I think Pine Rest is not just a hospital. I think they also have a treatment side if I'm thinking about it correctly. Breakdown of those. Within the level of care, there are different variables that are defined. So there's the care environment, the clinic services, the support services, the crisis resolution and prevention services. And so these provide kind of an overview of the kinds of things that would be expected. They are not prescriptive, and that's really important because they do list different services, but they do not list all of the services that we provide. Again, LOCUS it's not a state of Michigan thing. It's used, I think, internationally, at least all over the country. I don't know how broadly, but it's not a Michigan thing. It's not from Michigan. So it doesn't have a direct interplay with the Michigan Medicaid Provider Manual. So looking at the LOCUS manual and you're looking at the clinic services that are listed, it does rates of contact, which are really have a really big range at times, and kind of what that care environment might look like, which part doesn't tend to affect us a whole lot, quite frankly, because most of our services are some type of outpatient or community-based. So it has more to do more of the clinical services, supportive services, and the crisis state seen as influencers to help us in treatment planning. But again, if there's not listing certain services, that doesn't mean that they're not appropriate for a particular level of care. And they're made to be adaptable and flexible and fit a broad range. So that's why they're not completely specific. So prevents onset of illness, limited magnitude of morbidity, developed for individual or community application, variety of community settings. So again, this is not the population that we're working with. Recovery and maintenance. So 10 to 13. So people are independent. They might be in some services, but if they're in services, they're like this is UPHP level of services generally. Sorry, I'm just grabbing my notes here too, just so I know I've got a few in here. Yeah, so somebody, again, they might kind of pass through recovery and maintenance on their way out of our services. They're doing well, but we're not letting them go quite yet because we're supporting their transition, that sort of thing. And so they might score within that range, and it could still be appropriate. We would technically be providing a higher level of care, so that'd be an example of an override. So you can see, like with this, so the care level, individual and group supportive therapy up to 2 hours per month or once every 3 weeks, physician contact once 4 months. It's pretty, that's quite a range. So, but it's clearly a mild to moderate level of care. Low intensity community-based services. Also much more likely to be that group that would fall under UPHP or somebody who's transitioning out. It's more traditional clinic-based and not other types of services. But again, the range up to 3 hours per week. Now, as soon as you read that, that sounds like something we might do, but not less than 1 hour every 2 weeks. Well, we got some people that might fall into that too. So don't let our practice necessarily skew you around it. Generally speaking, what they're looking at is low intensity community-based is in that mild to moderate group typically for people who are kind of coming into a service. All right. Again, you cannot base a denial of entrance to services because someone scored a 16. You got to have other justification besides that, and you can't admit specifically only because they scored a 17 on the locus. Clinical justification for the combination of their diagnosis and impairment. Okay, high intensity community-based services. So that's 17 to 19. They need intense support and treatment. Be capable of living independently or with support in the community. We definitely do both. May require contact several times per week. Traditional clinic-based programs, both maybe up to 3 days a week, 2 to 3 hours per day. So that might be, there could be some CLS activity in that. Clubhouse would fit in that. There's a number of things that could come together where the person is receiving some type of service or support from us multiple times a week to several hours a day. And that would all appropriately fall into this high intensity community-based service. Level 4, medically monitored non-residential. So it's a 20 to 22. They're capable of living in the community in supportive or independent settings, treatment needs, intensive management by multidisciplinary treatment team. So it's this level 4 and 5. I've had a hard time kind of wrapping my head around personally, I'll be quite frank with you, about where our specialized residential homes fit in that, where the general AFCs, the mom and pops fit into this. And I haven't really been able to get a straight answer out of anybody when I've asked about it. In fact, I've gotten some inconsistency in the answer, quite frankly, because the locus doesn't really take those settings specifically into account. So when you're looking at information specific to the locus, when they talk about the level 5s, monitored residential services, what they typically are talking about are brick and mortar institutions where all the care is happening. So the therapy happens there. The doctor sees them there. They live there, right? It's all there, right? People in that. That's a pretty small part of what we do. But at the same time, then the level 4 is really, it's described as capable of living in the community, either in or supportive independent. It identifies ACT in there, the care environment. So, that's a little bit trickier for me. And I'm not sure what the hard line is, or even if there is a hard line on that. Now, granted, there is a continuum when you think about our residential services when we look at the AFC. So there's a big difference between a mom and pop and Life Options, for instance. Now, Life Options isn't an MI home, so in some ways it's a bad example, but it's a good example from the standpoint of the amount of of structure that is in that place and how much active treatment may happen there on a day-to-day basis. So if someone's in a specialized residential, they should fall somewhere 4 or 5. I tend to think that the way that it works, based on the inconsistent feedback I've gotten when I've asked about this, that our specialized residentials most likely are going to fall in the level 5. I think that's where they would be. One of the things that NorthCare is part of a larger group working on is, so right now our level of care in Elmer has nothing to do with LOCUS. So the benefit package is in there, doesn't line up with LOCUS. So they are looking to line all that up, and hopefully what that may do for us in the long run is help with if someone's in a mom and pop versus in a specialized residential under a special contract, that sort of thing, that it might help make the distinction a little bit clearer between the level 4 and the level 5. So I, like the rest of you, am continuing to learn on the LOCUS. I do not consider myself an expert on it. I've received some additional training on it, still trying to figure it out too. So this is one of those areas that it's not as clear cut for me. Okay, but I think it is important to know. So like the level 4 says medically monitored non-residential, and the level 5 says medically monitored residential. This doesn't mean that a doctor is directly monitoring something. The language is a little funky, in my opinion, for our world. So this could kind of skew a little bit about the way that we think about it. So I would pay less attention to that. Think more monitored I like cross out the medical in my own mind. Monitored non-residential, monitored non-residential, monitored residential services. Okay, and here, I don't think that this is what they're talking about. I think it's actually 4, but that's, like I said, that's confusing. I've gotten different answers from different experts on it when I've asked the question. So I'll continue to work on that, and as I get a better understanding of it, which hopefully I would, then get the word out. So where that override comes. So you'll see nothing there, but all that, or not the override, but the independent criteria that we talked about earlier. So 4, if you score a 4 in any of those first 3 dimensions, I automatically say a level 5. I do. You can see in some of the level 5. So for care, clinical care 24/7, psychiatric contract weekly to daily. See, that's where I don't think it's our group homes. I think our group homes fall into that level 4. That's what my interpretation has been. I only keep going back and forth on this and keep bringing this up because when I have asked specifically about it, I've not gotten a straight answer that has qualified that. And sometimes I've gotten the answer that it could be a level 5, which is not a helpful response. But when I read the care, this level 5 does not, like, they're not getting psychiatric contact weekly or 2 daily. Medical services should be readily accessible. That's not necessarily true in a group home. Up to 40 hours of nursing. Treatment 7 days a week. That's arguably the case because we're paying for community living support, and that's considered treatment. Therapy, rehab, education, either on-site or off. So I don't think that that's where it fits. And then we have the medically managed residential services. It's the most intensive level. It's provided in hospital or freestanding non-hospital settings. So it's a small group of who we serve. So state hospital falls into this. Interactions would fall into this. So there are a few places that we do work with people to go to. They can't live independently. They may or may not have been involuntarily committed to the treatment. And a 5 on any of the first 3 dimensions will automatically require this level of care, which are right there. So this is, again, clinical care 24/7. nursing 24/7, physician contact daily, treatment provided daily, individual, group, family therapy. So this one's pretty straightforward. All right, that one's really pretty easy. Somebody scores that high and they're accurately scored, significant concerns about them being in the community in any type of community setting. And if they need, we would consider for state hospitalization or interactions or someplace like that, things are not going well. Things are really intense. I've touched on this a little bit, but here's some of the nuts and bolts of the scoring. I apologize in the way I got to record this, so I can't take a break or it messes up the recording. And then we have multiple recordings, so I am trying to just soldier through the whole way. And I'm trying not to get too tangential while I'm doing it. So I appreciate a little grace from all of you on this. So as I touched on, each of the dimensions has a 5-point scale. Each point has one or more descriptors. You choose or circle all the descriptors that apply to the client. And the points are assigned by choosing the highest point number where at least one of the criteria is circled. So if you see things in the 2 that are true and fit, circle them. Something in the 3, not the 2. Test this actually. I wish I would have now. Well, this of course is assuming kind of a paper and pencil approach. I can't think about the top of my head if Elmer allows you to select more than one. So it's not just focusing on the highest that are correct. If it does, then it shouldn't matter. You should be able to do just what the slide is saying. But I did not, I apologize, I did not think to test this out in Elmer to see ahead of time. We're assigned by choosing the highest point, where at least one is circled. It disregards the low scores even when there may be more than one of them. So it doesn't matter how many lower scores there are. And in fact, doesn't matter how many, how many you selected in the 3, it's gonna grab the 3. It's the level that matters the most. When you're scoring, always stand back and look at the criteria chosen and think about, does it make sense to the thing. So there are different options within each of the to choose from. Will be pretty spot on and will match pretty well. Some people, though, in some of the categories, none of the statements will be a perfect fit. They just won't be. So for those of you who use the CAFAS, personally, I find the CAFAS does a little bit better job of, if you're just focusing on the facts, of being able to find the right one that might match. But they have more options in some of the categories than what the LOCUS does. Sometimes the LOCUS only has a small handful. So you do have to think about the criteria from the standpoint of the level of intensity that it's getting at and the level of intensity for that category for the person. So if they don't have a statement that really hits what's going on for the person, what is that level of intensity in that particular criteria that the person is dealing with? But that's what you have to push towards. Error on the side of caution. And choose a level of need that exaggerates the client's situation, in your opinion. So what that's getting at, there's another truthism in LOCUS. If you're undecided between 2 levels, say a 2 or a 3, you're not sure which, then go with the 3. That's the caution that it's talking about. That it would rather that we over-provide versus under-provide. So that's what it's talking about. Mindful. So for example, let's say I'm torn between a 3 and a 4 under risk of harm. Now, one of the things I know is if I put a 4, it's going to bump the person into that first level of residential care. And if I don't think that's actually the correct level of care for the person, and I'm up in the air between the two, like truly up in the air, three may be more appropriate. Again, not scoring in order to avoid the residential option. If there's something in that 4 that I actually think is accurate and correct and is the most correct, then I need to score that. I may need to do an override, but I need to score that. But if I'm kind of up in the air on it, both kind of fit, I think the resulting level of care is correct, appropriate for me to pick the 3. Is it saying? So be cautious. So you caught between 2, typically you're going to go higher. That's being cautious, but you don't always have to do that. It depends on whether or not you think it's exaggerating the person's situation. Use everything you know when you're scoring. Everything you know about the person, every source of information. Again, the locus is supposed to happen in conjunction with the completion of an assessment. That may not be true at time of discharge. You don't have to complete a new assessment at time of discharge, but even with the discharge, with a planned discharge, there is some assessing that happens as part of the discharge. So we don't end up writing a BPS. We end up writing a discharge summary. But there's still some assessing of progress, where they're at, that sort of thing. But under the other circumstances, it's in conjunction with us having conducted an assessment. And so information. If someone is living in a group home, have the information about how they're doing from the people who work with them. The family are involved, have information from them. You want to have as much as possible. That the more data you have, more accurately you can score the locus. Remember, you're concentrating on the here and now, on the current needs. Although in treatment history and risk of harm, past history is important too, but in all of the other areas, we're really focused on now. What's going on now, okay? Not getting caught up in the past. So the composite score is based on the 7 scores obtained in the 6 dimensions. So remember that environment one actually has 2. So there are dimensions, but environment has an A and a B. So you get one is risk of harm, 2 is functional status, 3 is comorbidity, 4 is recovery environment, but it has the A and the B. 5 is treatment and recovery history, and 6 is engagement and recovery. So the total score is based on these 7 scores that come out of the 6 dimensions. So remember, you choose the primary presenting issue first to score against. It will always be a behavioral health. So theoretically, if somebody comes in and most of their problems are substance abuse, their LOCUS score could be pretty low, right? Especially if you're going to, and if they are somebody that you would deny and refer to substance abuse treatment because that's really what you think is going on, your LOCUS should score low then. Primary presenting issue to complete the evaluation, even when they're duly diagnosed, or other problem becomes a comorbid condition that's only scored there. LOCUS exceptions. You always evaluate the client as he or she is now. Exception. If a client's in a residential environment, the recovery environment stress and support scores, so that's both A and B, are based on the amount of stress and support they would have should they leave that protected environment. Now, regardless of all that confusing stuff that I let you in on in regards to the difference between the level 5 and the level 6, the level 4 and the level 5. Sorry about that. I've been talking now for an hour and a half straight. So the level of 4, medically monitored non-residential, or level 5, medically monitored residential, and where exactly the group homes fit into that. That aside, scoring the recovery environment, stress and support, about if they were not living in the setting that they're living in. Asked about that also. I actually got a straight answer on that one. So I'm very confident in what I'm saying to you right now. So that is, I live at Wright Street. I were to move out into my own apartment, what would that look like? That's what we score. Not how I'm doing it right street. Okay. Do composite scores based on 6 dimensions, 7 scores. That seems redundant. There's a locus placement grid and there's a locus decision tree. So the decision tree specifically, that's include this in the attachments. So I'm recording this now. We're going to have it put on NetSmart, which if you're watching this, hopefully it's on NetSmart. And my plan is to have a number of documents as attachments that you can download, save to your computer and have, and the decision tree is one of them. The decision tree, for some, depending on the kind of the way you think, it's helpful in trying to look through the way that you would score somebody in different circumstances. So I want to make sure that that's there. Electronic version, therefore it automatically takes the composite scores and makes the level of recommendation, care recommendation. Typical errors. Now we've hit on some of these already. About an hour and a half. And as obvious through this presentation, my ability to focus has gotten a little bit impaired and your ability to listen may be a little impaired at this point. So a little redundancy is in order. So I mentioned loading stress into multiple dimensions. That specifically is dealt with in recovery environment. That's where stress goes. So if the person is under a lot of stress, you're looking for it. Really careful about their heightened state stress response and placing it in the other categories. It will inflate the scoring. An error, I believe to be the case. Perceived stress versus real stress. I touched on this also. That has to do with what we think is useful for the person. Or may not be. The reality for a lot of the folks that we work with, they're more comfortable with high levels of chaos than we are. May absolutely know people that are not really very worried about being homeless. It definitely stressed me out. I don't have the skills necessary at this particular point in time to successfully be homeless. But some of the people that we work with absolutely do. And being homeless is not a stressor for them. So just because it would be a stressor for us does not mean it's a stressor for them. And so even within that recovery environment component, we don't want to score stress if we don't know it's stress. And it definitely shouldn't be ours. Forecasting. This is a really easy trap to fall into because we do it all the time and appropriately, right? So we work with people a lot of the time that we do need to be thinking about the direction that things are going for them, how they're doing, and where it might go. We forecast a lot. A big part of my job is forecasting, right? I've done it during this training, talking about what NorthCare is going to look for, what the department will look for, concerns that they are going to use, how they're going to use the data around the locus, right? That's all forecasting. None of it is specifically given. Now I'm forecasting based on information that has been given to me, but it's forecasting. It is. I don't actually know for a fact. Maybe the department will get distracted and they'll forget all about the locus and no one will ever talk to us about it. I think that will happen. I don't really know. I'm forecasting, right? So I have to do forecasting clinically, administratively. It's a very appropriate skill to have. It's good to be good at. I spend a lot of my time looking around, thinking around corners for things that could be coming so we can try to be prepared for things. Forecasting is great, not in the locus. Don't forecast on the locus. Clearly, when we forecast, we tend to forecast, again, appropriately. We forecast thinking about the worst case scenarios. And that's great when you're trying to prepare for something. It's good for crisis planning. The locus we are trying to identify as accurately as possible, quantify the person's need and risk. Casting skews that. Resist that. Scoring substance use on every dimension. I've hit this, I don't know, 4 times now. I'm going to hit it again because it's really easy to do. So for instance, an example. Okay. Risk of harm. I'm going to go through the risk of harm. So, so I'm looking at the moderate. So let's say I think the person is going to fall in this moderate range. Moderate risk of harm. Significant current suicidal or homicidal ideation without intent or conscious plan and without past history. Oh, sorry, I'm stressing the conjunctions. The conjunctions are incredibly important. I think it's listed up here in one of these panels we haven't gotten to yet. Conjunctions. Okay, so that's A. B, no active suicidal, homicidal ideation, but extreme distress and or a history of suicidal, homicidal exists. Okay, so let's say so far I'm not thinking neither of these are working for me, my person. C, history of chronic impulsive, suicidal, homicidal behavior or threats, but current expressions do not represent significant change from usual behavior. Yeah, that's not the person that I work with either. And then I get to or excessive use of substances resulting in potentially harmful behaviors in the past, but there have been no recent episodes. Person has that history. So I go, oh, D. Nope, it's not 3D because not the presenting problem. The presenting problem is behavioral health, not substance use. So 3D is incorrect. And 3M is 2A, no current suicidal or homicidal ideation, plan, intention, or severe distress, but may have had transient or passive thoughts recently or in the past. So that's actually where it fits. I bump them to a 3 because they had high-risk binge drinking behaviors in the past. From a 2 to a 3. So that's how easy it can happen. And that's why I keep hitting on that over and over again. The chronic versus acute, the restrictive settings, I'm skipping that because quite frankly, I don't remember why it was in the slide. It's not my slide. So, and I didn't delete it. So I'm not sure what they were getting at with that one. Chronic versus acute, again, hit on that many times. Chronic scores lower than acute. Chronic is can be a 2 or a 3 or higher. Acute is at least a 3, 4 or 5. And that's in all the categories, all the dimensions, all the way across, no exception. So collect complete data. Make sure you know, right? Use the LOCUS more and more. Those of you who are already familiar with what's in there, you know, when you're conducting an assessment, think about the questions that the LOCUS are going to have. Use those the dimensions in your assessment, so you can specifically be asking questions that will help you answer and score the LOCUS. I think that's one of the things that can easily lead to misscoring, particularly with people that we may have worked with for a while. The reason that we have, well, there are a number of reasons why we have to assess annually. One is because people's needs do change. Always, or at least not dramatically. But what can really happen, particularly when we're working with people who have intense problems and we work with them for a long time, it's really easy to think we've got a handle on everything that's going on for them. But things may have changed that we don't know because they can't tell us everything and we can't see everything. And if we don't ask, sometimes we think we know We don't. With people we work with for a long time, there can be a tendency to kind of, we've got an understanding. We just don't even need to investigate. So what assessment does is it forces us to really relook at the situation and relook at what's going on for the person, and make sure we haven't missed anything. That's why in trauma-informed care, you don't just screen for trauma once. Because sometimes people will answer the questions differently after the relationship is more established. And so, like that with LOCUS, if we don't ask the questions that address the dimensions, then we are effectively guessing. At least that's the risk that we're running. You absolutely may know the people that you're working with really well. I get to know the people I'm working with really well, but I tell you, I just recently I used a different assessment tool, just a quick one with somebody that I've known for years, and I was surprised by some of their answers. They answered in some ways that I was not expecting. So I think that we know all the answers to these things, but the reality is that we do a much better job if we actually take the time to dig into it a little bit more. And we may be surprised by some of the answers. So you can be thinking about LOCUS when you are doing your assessment. When you're looking at presenting problem, you can flesh out some of the LOCUS in that pretty easily. When you're thinking about about diagnosis and impact a symptom for substantial limitation on function on LOCUS. Okay, do not load stress on all dimensions. We've talked about that several times, so please don't do it. Keep stress for where stress belongs. And then, as I touched on before, generally, if you can't decide between two scores, then choose the higher one. If you're truly on the fence, if you really think they both kind of seem true, then generally speaking, the right answer is to score the higher one. That's the conservative choice. Again, if you think that where that ends up is a higher level of care that is actually appropriate, and that's the determining factor, then you could consider picking the lower one. But that's the basic rule. So while scoring about the client's baseline, what does that look like now in relationship to their baseline? So if they're baseline, where are they now? About the same. Then you're looking at chronic scores. Different. Worse. Now you've got the potential for some acute scoring, okay, which could make things different from the last time the LOCUS was done. I touched on this when I was reading. Look at the operational words and, but, or, nor, with, without, etc. They're very important and easy to blow through when you read. Related to that, grading somebody, you really should read them all. Read them all. So there's a rule in CAFAS that does not specifically carry over to LOCUS. So there's a rule in CAFAS and PECFAS that you start with the most severe and you work your way down and you read them all. Okay. I'm not recommending that at LOCUS because they don't recommend that with LOCUS. But I think what we can take away from that is with the one, which is minimal risk, or it's minimal, right? Or no, depending. So a one is basically nothing, no problem, or normalized problem. The one, read them, read the three, read the four, read the five, read them all, and read them carefully. Pick the right one. You can, if you're kind of doing it in paper, or again, if Elmore will let you do it electronically, hit the ones as you're going through, hit the ones that you think are true. Go ahead and do that, but go through all of them to make sure that you hit the level of the ones that make the most sense. So this was a tip in the training, and that had to do with actually using the manual. Part of what I'm hoping to have as an attachment is is also not the manual, but actually just the scoring component of it. So it's not as long, doesn't have all the instruction on it. But what they suggested was, and the trainer held it up, and his was all color coded. So when you've got this book and you're looking at comorbidity, there are trends, levels. When you see those themes, like highlighting them so that they jump out to you a little bit more. So that was one of the things that they recommended to make it easier to locate what you're looking for and to break it up. I want to make sure everybody has a book, or at least has the scoring sheets themselves so that they can be looking at that. So you can do what you need to for your own style to make it more effective. Yeah, okay, so that's it. So done sharing my screen. Oh, actually, no, I'm not. I wanted to go through something, sorry. Go, I had an idea. So what I have here, when I was giving credit for where I got this information, so this was the two ladies that work for MyFast. This is their slides. So I kind of liked this. So they have already gone through this. This training was provided via tele not all that long ago. So you can see some of these looks a little familiar, right? Okay, so I liked this, right? So problem solving of stress. So if we were together, if we were doing a traditional training, one of the things that we would be doing that would make it a lot easier to get good at this, quite frankly, would be there would be practice vignettes. There would be, here's this guy and here's his story and how would you score him? And you get together in groups and you would go through and you would score them, and then we would go around the room and we would talk about it, and we would talk about the how you reach those decisions and what the correct scoring would look like. Doing that, and that does make me a little bit nervous on how well people will be able to do, because the practice really does help. That before we're done too, as far as how you can practice before you do the test, before you do reliability tests, and I encourage this. But anyway, so I'm going to go through these couple of scenarios because I thought they were helpful in addressing some of these high error rate that I've drilled into the ground. So Bob has been drinking for years. He drinks 10 to 12 beers daily. He uses alcohol as a way to escape his feelings of sadness. His girlfriend kicked him out of their house due to his alcohol use. He recently relapsed and has been in a residential facility where he has been clean. Now, this is a rough example because I've just spent time talking about substance abuse is in the comorbid, but example, Bob's presenting problem is okay. So how would we score it? Here's what it would look like. So let me find their functional. So based on this little one, we can't score all of it. We can't score an entire locus based on this little bit of information. Here's where we would score based on this information. Status would be E, would be 3E or F. So 3E is ongoing or variable severe deficits in interpersonal relationships, ability to engage in socially constructive activities, and ability to maintain responsibilities. And F, recent gains or a stabilization in functioning have been achieved while participating in treatment in a structured and or protected setting. That last part, he just went into the facility where he's been clean, right? So that's the F part. And all this other stuff is really the E. And then comorbidity. recent use but has been arrested due to. Okay. Oh, that's 3E under comorbidity. So 3E, recent substance use which has been clearly detrimental effects on the presenting disorder, but which has been temporarily arrested through use of highly structured or protected setting or through other external means. So that's what happened, right? Kicked him out, recently relapsed, and has been placed in the residential. Stress. Them up on that one, sorry. Okay. So let's look at this one. So this is the perceived or actual stress. So Melanie shared with her case manager that she's homeless. She has found a shelter and is staying here until this works themselves out. She expresses no real concern or worry. Case manager does a new locus due to homelessness and scores her a level of stress at a 4. So remember, it's 5 points. So 4 is next to the highest. Is this an appropriate score and why? Talk amongst yourselves. It's an inappropriate one. Melanie is showing some signs or expressing acute stress. There's no need to score her higher. The clinician should not score based on their perceived stress, but on the actual stress of the person. Okay. All right, about this one. Forecasting. Mike has cirrhosis of the liver and is following up for medical monitoring. He reported he recently noticed some discoloration, yellow of his eyes, and also experiencing profuse sweating and dizziness. Preliminary diagnosis is it may be cirrhosis of the liver. We score this in comorbidity. Scores 3A in comorbidity for medical conditions. Medical conditions exist or have potential to develop, which may require significant medical monitoring. It's not scored higher. We don't know what's going to happen. So we only use what we know. So for that, so he has the cirrhosis of the liver, is following up, has some symptoms that suggests it, right? So we know it's there. It's a preliminary diagnosis that it may be. So we don't even know it's there. We know there's a probability of it there, right? So the 3A, there's a medical condition that exists, potential to develop. That lines up, we know that. Where the forecasting comes in is we could easily jump to a 4 and say medical conditions exist or have a very high likelihood of developing, require intensive, although not constant medical monitoring. That's where we could go because cirrhosis of the liver is pretty serious, right? So easy to drop there, but we don't know that. We don't know that part. What we know is what it says there. Medical conditions exist, have the potential to develop, which may require, period. We know. Here's another one. Sean uses alcohol nightly. He often drinks a 12-pack. Last week he drank. He drove his car and ended up in a ditch. What would we be thinking about for scoring? For serious substance use disorder, we only rate on the comorbid for us. So this one tracks for us specifically. Be sure not to rate it on both risk of harm and or functional status. For risk of harm, the only time you should rate the substance use is if the behavior when using puts them at risk. Here it gives the example of the difference between the two. I should have went here first, sorry. So this is risk of harm because of he drove, ended up in the ditch. So we can score this one in risk of harm because that was dangerous behavior, specifically connected. If he was drinking a 12-pack nightly and sleeping or staying home, we would not rate it. Irrelevant. Show up in the comorbid. That was clear. I looked at these, seems like days ago now. Okay. Restrictive settings. Linda has been in a long-term residential setting. Oh, I think I know what that was. Okay. Sorry. Which is full-time staffing. Staff help her take her medications and monitor her behaviors, which helps to monitor her voices that command her to do things. How would you rate Linda for stress and support? So we rate Linda for stress and support as if she were leaving. What would her stress be like if she were trying to manage her medications and her voices on her own? So that in that earlier slide that listed restrictive settings, and I couldn't remember what it was for. This is what that was talking about. So see, I over prepared and just couldn't remember. That's what happened. Acute, chronic versus acute. So Jennifer has had suicidal ideation all of her life. She is often melancholy and feels like it would be okay if she weren't here anymore. She's never attempted suicide. Her baseline for Jennifer. This as her baseline. Chronic suicidal ideation, which would score lower. If Jennifer all of a sudden reacted to the voices and tried to cut herself, this would be more acute and her score would go up. Okay, so we've covered some of that stuff. Okay, so we're done with that. So I hope you're all still with me. So, in preparing for the greater reliability. So if you have access to a training manual, you do, in the back of the training manual, that's so you can't read this probably. So, there are cases. And you can read the case, or based on the locus, which is also in here, or is an attachment to this training. And this, the answers in the back. And so that's actually, we're not allowed to use these for rate of reliability because in the back of the book are the answers. So it doesn't help us for doing the rate of reliability, but great for practice. And I cannot stress enough how important it is for you to do some practice and check your answers and look at why they scored differently than you did before you do the rate of reliability. It's really important. I'm saying that from my own experience. So when I went through my formal 3-day training, we're way off from what they were saying were the right answers. And it really took looking through those to, not always, not all my scores, but there were times when it was definitely, I would underscore, I would overscore, having a hard time kind of finding the sweet spot. Got better because we practiced. And that is one of the things that's a big missing piece in this training modality, is that we don't have a way to practice. So take the time and practice it before you do the rate of reliability. So there's only a few rate of reliability vignettes. It's not a long, like that itself isn't going to be long. If you get them right, you'll be done for a year. At some point we have to figure out a way to, we have to do some way to demonstrate that you're not drifting. So we've got to figure that out yet, but you don't pass it, then we got to figure out how to get you to pass, which is going to take more time. I did this way because I know you're busy. I know you got a lot going on, and I wanted to take as little time as possible from you and I wanted to try to create as much flexibility for you as possible, and therefore having the book and going through it yourself. You can do that at kind of at your own pace to some degree. Um, that being said, October 1st is when they're going to start really looking at our data, or at least the data that is generated from October 1st. So a lot of time from this recording. This is being recorded on 30th. Original plans was to do all of this, to do the training, to do live training in April of this year, or maybe May, if I or both, because I was going to do it in multiple settings. We all know what happened to April and May this year. So that's why I'm doing it the way that I'm doing it. I am completely cognizant that this is probably not the most solid way to train. So the other thing that I would I want to offer is you take this training, you look at the book, questions about something, please get in touch with me. Know what you're thinking. We can try to think through the circumstances together, that sort of thing. I want to try to help you any way I can on being able to sort through what it is. And so even if it's, say you do the vignettes, you look at the scores and your scores are different and you're not really getting why, then we could look at them together and try to help you see, maybe what's going on there. Okay. I'll be able to support you any way I can on this. So don't pass the radar reliability when you take it. We'll figure out what to do from there. It just means we're going to have to do some more stuff. Okay. So I also don't want you sweating about it, right? So my point in bringing up about that is not to get you stressed on it. It is to stress that I really encourage you not to walk in blind on it, but to do some prepping to get prepared for it. But ultimately, I don't have any doubt that we'll get everybody through it. I've been our CAFAS and PECFAS trainer for several years, and I have yet to run into a situation where somebody could not become certified with radar reliability for CAFAS and PECFAS. Everyone has always done it. So I'm going into this thinking that that will be true for this as well. I have no reason to think otherwise. So do it. And not having had any practice opportunities during this training, which is a big part of why the trainings are a couple of days, because there's hours dedicated to practice. Going in cold without practice be a problem. I actually think if you've been using the LOCUS for a couple of years or more without actually having been trained, you think you got it, give the vignettes a chance to see whether you got it or not. Because as we went through, like I said, I mean, I've seen LOCUS by people who've worked here for quite a while that were scoring substance use in every category, we're scoring stress in multiple categories. I've seen those patterns for people that have been LOCUS users for pathways. So encourage you to do a little bit of homework first to make sure. I really want everybody to pass. First time around, because that'll be the quickest for you. That'll be the least amount of work, and you're all busy. So this pretty much wraps this part up. I was hoping to get it done in about 2 hours, so 2:04 according to my counter. I hope this worked for you. It's the first time I've tried to do this, so I apologize for any less than professionalism in the recording process that this might have. And again, please feel free to ask for assistance, shoot questions my way, that sort of thing. Thank you very much for your time. And if I can get my mouse to work, I'll be signing off. All right.